we start a new thematic group. For the next 3 weeks, we will be talking about palliative care and its place in humanitarian crises and emergency situations. And we'll be talking about different aspects of this. I'm so delighted to introduce you to our facilitator for today. Some of you might already know Joan or have certainly read about Joan or heard her speak on different forums. Joan is, she's a very dear friend of Pallium India's and is, well, her training has been as a nurse. She's a registered nurse. She's a volunteer registered nurse. Joan is joining us from South Africa. She was the past executive, chief executive of ICPCN, which is the International Children's Palliative Care Network, and is co-founder of PalChase, which is palliative care in humanitarian aid and emergency settings. Yes, I always get that a little bit muddled. But they do some fabulous work across the world, working with all kinds of groups, including refugees, children, lots of marginalized communities that are particularly vulnerable in a time of crisis. So Joan, thank you so much for being with us today. This is a very diverse group of people, which I keep introducing every week. Amongst them, we have not just social workers, we have counselors, we have cancer survivors, we have caregivers, doctors, hospital administrators, name it, and they're part of this group. So it has been absolutely wonderful interacting with them over the last few weeks. And how this usually works is that I will be collecting the comments and questions that come into the chat box and passing them along to you as and when you're ready to take them. So if you could just say a few words and then we can begin. You're on mute, Joan, sorry.
There we go. Thanks so much, Smriti. And it's always an absolute delight to be with you at Pallium India. And we're going to be together again later today. And to talk about palliative care in humanitarian situations, because it's a really relatively new field. We're still finding our way. There's different models developing and some strong themes coming through, but there's no real expertise in this field. Some people are more experienced, but there is a growing body of people who acknowledge and recognize that palliative care is necessary in humanitarian situations. There's an acknowledgement by the World Health Organization, and there's a World Health Assembly resolution on palliative care for COVID. And of course, we're all working in COVID and in this present humanitarian situation. So I'm going to share my screen now, and it will be a delight to talk to you. And please ask questions, and if I don't know the answer, then I will get someone who does. Is that okay? Can you see my screen?
No, sorry, ma'am, we cannot see it as of now.
So you can't see it yet? Okay, I wonder why. Let me see. Why is this not? And now, any luck?
It's still not visible. Could you please try again once more?
It's up on mine, and I'm not sure why.
Yes, yes, it's up now.
Okay.
It's just starting. Yeah, there you go. Yes, it is.
Okay, that's great. And please, put any questions in the chat, and I'll try to answer them. But those that I can't answer, I will email the responses to you. So today I'm speaking on behalf of PalChase, and I'm going to give you a little bit more background about PalChase and about what we do. And the components we're going to look at today are going to be where humanitarian crises and palliative care meet. Issues around vulnerability and suffering, and of course we see such extensive suffering in humanitarian situations. We'll look at the psychosocial, cultural, and spiritual areas in this situation, and how when you have very few resources and you have a lot of people to deal with, you have to be flexible, you have to be resourceful, and you have to be able to improvise. And then I want to share with you just a few areas where people are working in humanitarian situations with palliative care, and the themes that are really coming through now of what is successful. And then when we look at grief, I'd like to include children because, in fact, my really speciality field is the field of pediatric palliative care. And the learning objectives, of course, are all linked to that. So I don't think I need to go through them with you, but they are linked to what we're going to be talking about today. So where does humanitarianism and palliative care meet? In many fields. And what is a humanitarian crisis? So we need to look at it as a critical threat. So we have small crises, maybe an upflaring of violence in a place, a fire that bursts out, but they are reasonably well contained, and they're not a critical threat to a large number of people, a large community, and they may either be internally in a community, inside a country, or of course they may spill out across borders and across countries. And the response, health is just one part of the response to a humanitarian crisis. And really, we cannot separate it out of the other responses. One thing I have been really impressed about since starting to do some work in this field is that the coordination from the UN, from WHO for the health is really strong. And I think that we could all learn a great deal from it. And then we have complex humanitarian emergencies. There's a whole vocabulary that we've discovered around humanitarianism, and they talk about CHEs. And these are crises which are on top of an existing crisis. So where there's already a breakdown in organization and there's conflict within an area or even across borders, and on top of this, we get another crisis, and these are called complex humanitarian emergencies. And the interesting thing, I love history, I really do, but the impact of war on the development of health services has been really profound. We can look at Henri Dunant, and who started the International Red Cross and Red Crescent, resulting from the Battle of Solferino. And out of that, we got the Geneva Convention, which is around the protection of prisoners of war. Save the Children after World War I, the International Rescue Committee after World War II, Médecins Sans Frontières out of the Biafran War, and SAMS out of what is happening in Syria. So the impact of war has been profound. And of course, because this is the year of the nurse and the midwife, if we look at modern nursing and what we know about hygiene, hand washing, it all came out of the Crimean War and the work that Florence Nightingale did there. So there's always something good that comes even out of the worst situations. Then, of course, whether we're working with palliative care or a separate part, non-health part of humanitarianism, if we look at the whole package, we're looking at suffering that is really profound, an enormous amount of emotional and spiritual pain, quite apart from the physical suffering that everyone undergoes. And so it's no surprise that mortality and morbidity increases in humanitarian situations. And this again is an indicator that palliative care is necessary. So whether we look at the standard WHO definition of palliative care, or whether we look at the revised consensus definition, suffering is at the core of it. And so we're both we're both there, the humanitarian response groups and palliative care. We are here to respond to that suffering. It's how we do it that makes us different. And so when we look at the whole picture, the whole humanitarian emergency, we first have to look at the population we're dealing with. And of course, within that population, you're going to get across all ages, and you're going to get one or different cultures, perhaps many different cultures that are very different to those who are responding. So a knowledge and an understanding of the population is absolutely essential. And then the context, if we even look at COVID-19, which is really, it's made such a profound impact on the wealthiest countries in the world. So how much more are the countries which are already just surviving, have they been impacted by this great humanitarian crisis? So we need to look within the context, what is the health system? Is that health system reasonably strong? Or unfortunately, what we see when most of the humanitarian crises arise, they arise where the health system is already fragile. And so a lot of resources have to be brought in. And then we'll look at the resources, and of course, not just things like bringing in the opioids, it's what are the resources within the country? What is there that can be built on and strengthened? Because one of the main functions of a humanitarian response is to create strength and leadership within the communities there, and not to create dependence. This is very, very important. And if we remember that, it really will impact on the way that we provide our palliative care. And as I mentioned before, we cannot do it alone. Palliative care cannot be standalone. It needs to be part of a collaborative approach, and we need to be very open to the collaboration from within the country, with the UN agencies, and with the other response organizations. Oops, what's happened there? Oh, here we are. So these are really just some of the heartbreaking pictures that we see in the different humanitarian crises around the world. And each one breaks your heart when you look at it, and you cannot imagine just living through those kinds of situations. And one often feels so helpless because the need is large and the resources are really small. And this is really where Palliative started. Do you remember in 2016 watching this? It seemed never to stop. Every time you turned on the television, you saw this long, long line of refugees fleeing from the war in Syria. And I used to look at those faces and think, you know, these are people just like you and I. These are people who were nurses and doctors and social workers and mothers and fathers and children who were playing and going to school, and grandparents who were looking forward to ease and comfort in their old age. And yet, because of this horror of war within their country, they were leaving everything that they loved and going into a totally unknown future. And so we're looking at loss and profound loss within this context as well. And while we are used to dealing with the loss and the grief that is there with our patients, the loss of life, the loss of their dreams, we were seeing it here in this just overwhelmingly large number of people. And I put out the question to the global palliative care community and said, I hadn't thought about it before, what palliative care is there in a humanitarian situation? And of course, the answer that came back was not very much. So it could be a conflict situation. And unfortunately, so many of these conflict situations are here in Africa. It could be a natural disaster. It could be a tsunami. It could be flooding, all of these type of things, earthquakes that we see. It could be because people are leaving their country because they see no future in their country, whether they are refugees or migrants. And of course, the largest number of displaced people are internally displaced persons within their own country. And yet their needs are huge and they are very difficult to reach because they're not in one particular place. And then, of course, what we all experience now are the pandemics. We as palliative care, I think we have quite a good idea of how we can respond on a small scale. But actually what we need to be looking at is we need to be expanding our vision to see how we provide the principles of palliative care in this enormous global pandemic. And we could learn a lot. I'm older now, and I worked from the beginning of the AIDS pandemic, and it was a pandemic in those days because we had no treatment, and it was popping up all over the world, and people were dying. And even in those days, we were learning on the job because we had no reference point. But with this pandemic, with COVID, we do have the AIDS memories that we can build on. And of course, more localized epidemics. And then the impact, palliative care, the development of palliative care in countries like Belarus and like Ukraine were very, very much a response to the nuclear disaster of Chernobyl. And you can see then how palliative care and disasters do link. And then, of course, that chronic poverty is a ongoing humanitarian crisis. And if you live and work in India, if you live and work in Africa, then you know that how difficult it is sometimes to provide palliative care within those resources. So we weren't coming from a zero base. We had the background, we have the experience of working in low-resourced areas where there is chronic poverty, and we know what works there. So while we were asking the question, we did have some of the answers to it. And at the same time, we discovered that in Geneva, that there was a survey going on about what the humanitarian emergency organizations were doing about palliative care. So we were asking about palliative care in humanitarian situations, and they were asking the humanitarian emergency organizations. And the findings were that palliative care was not generally in culture or practice. And certainly from the interviews that we did, though, it was people were saying, but that's basically what we're doing with Ebola. It was palliative care, and nearly everything they were doing was palliative care. But without the background or the training or the access to resources, or even knowing what the resources should be. But there were things going on. There were isolated reports of palliative care and pain control. And that was mainly in countries which had a reasonably strong palliative care movement. So there was something happening going on. But we recognized that there was definitely a role for some form of network. And I hesitate to call us an organization because we're a network joined with a single vision. And that vision is to integrate palliative care as far as possible into the humanitarian response. And so really, Palliative was set up to achieve what were the goals of palliative care. And that is to relieve suffering wherever it is, to relieve suffering for anyone who has health-related suffering, to promote quality of life through that, and our belief that palliative care is a human right, and that it doesn't matter where you are, whether you're sitting in Greece on a Greek island because you've come there on a migrant ship, or whether you're sitting in a war zone on the border of Ukraine and Russia, or whether you're sitting in an area of extreme poverty in India or Africa, you should have access to palliative care. And of course, it's based on the idea that everyone's lives matter. And that is a basic principle of humanitarianism and also of palliative care as well. And so as Palchase, we're a network. We're a network of individuals and organizations, and we are a partnership between people working in palliative care and in humanitarian health, who also have this vision of integrating palliative care. And it's open to anyone. There's no fees to be paid. If you're interested, join us, and we will join you into the communication. And we do have priorities. Our main priority is advocacy, because if we look at the size of the palliative care community worldwide, sure, it's growing, but it still is in each and every country, it is still a very small part of their health response. And so there is absolutely no way that we as a palliative care community, as we exist at present, could go into humanitarian situations and do it all on our own. We also recognize from working with Médecins Sans Frontières, with the Syrian American Medical Society and the Red Cross, that what they were saying to us is they needed education. So they recognize the need, but they need education. But along with education goes research. What kind of evidence do we have that palliative care is actually effective? Is it just this little bit of work that we do and it gets lost within the whole humanitarian health response? Do we have any evidence that it works? We know we have a wealth of research on palliative care, but in that particular context. And so, of course, one of the main things we're looking at is looking at where models are developing, seeing what is effective, and seeing if there are threads from all those areas that show us what possibly could be done in all humanitarian situations. And so our support for projects is more through advocacy, education, and research. And really it's to answer this that Dr. Fazana Khan, who has done the most incredible work in Cox's Bazar in Bangladesh, she said, nobody seems to care for these human beings and their unfortunate families. I have a database of over 1,000 people who need palliative care. And the patients and me feel totally helpless. I don't know how to stand beside them. And Fazana has gone on from them, and she is showing all of us how we can stand beside them with minimal resources, but with somebody who has a total passion to make a difference and to change lives. And this is the need, 433 million in need of humanitarian aid in 2020. That is huge. And we look at the proportions, 75% are women and children. And so within our palliative care, we have to be looking at what are we doing for maternal and child health. So we do have pediatric palliative care for children, and that is growing in strength. But within palliative care, it is still a very tiny part. It needs to grow, and it needs to grow quickly. And what are we doing for maternal and child health? And of course, the role of traditional birth attendants and midwives is so essential in palliative care. But we see very little being done for this particular group of healthcare professionals. And then living in Africa, it is heartbreaking to see that most of the need is within Africa, mainly in Central Africa, but impacting on all those countries around it. And that there's 70 million people forcibly displaced. And for every person who's displaced, they are experiencing loss and grief. Of the 26 million refugees at present, over half are under 18. So again, where is the pediatric palliative care? What are we doing to strengthen that element of palliative care so that we can begin to reach this over 13 million children who are in humanitarian situations? And then of the $40 billion that are needed to respond to this, only 43% is presently being used. And how much of that is actually going into children, into those under 18? So what was the resource that we saw that was already there? And we did see that. We saw that there was some literature, and it was at this time the WHO approached some of us and asked us to develop a guide on palliative care, pain and symptom control within humanitarian situations. And at the same time, they asked us to develop a guide on pediatric palliative care, pain and symptom management within that could link to the humanitarian guidance. Also, at the same time, if we're looking at guidance, the handbook that all the humanitarian response groups use is the Sphere Handbook. And at that time that we were talking about it, they had sent out a call for input into developing the first palliative care standard. And that was a really important step in palliative care in humanitarian situations, because once it's in the Sphere Handbook, it will be used by all the major humanitarian response organizations. And of course, there was some education that could be adapted for humanitarian situations, and there was some research that had started to take place. And if you look at the countries where we were getting reports of palliative care, in Greece, some beautiful, beautiful grief work that is being done with refugees, and also led by a pediatric palliative care group, Merimna. Bangladesh, Uganda, Jordan, Lebanon, all of these countries, something was happening. And so in countries like New Zealand and Germany and Austria, Australia, where there is a fairly strong palliative care movement, refugees were being seen by the palliative care programs. And if you have a foundation and it's a strong foundation, well, you can build on it. So how did we build on that? We looked at how we could fit into the coordinating structure. Now, the overall coordination in a humanitarian crisis is always by the United Nations Office for the Coordination of Humanitarian Affairs. So they have their primary responsibility to see that everything gets implemented. But the humanitarian health response is led by the World Health Organization. So if you're going to work with palliative care, we've got to be networked within those two groups. And then if we're working with children, of course, UNICEF is primarily responsible for children. And today is World Children's Day, where UNICEF is asking us to help to reimagine a future for children, a future that protects children's rights. And today we're asked to wear blue. So if you don't have blue on today, when this is finished, please find something blue to put on, just to show that you're in solidarity with these children, and especially with children who need palliative care. And we looked at who provides healthcare in humanitarian emergencies. And there was a huge range. I looked at what was a relatively small humanitarian crisis. And when I say relatively small, it was big for Nepal. But there were 148 different organizations that were involved in providing some form of relief within that region of Nepal. So can you imagine coordinating all of that? And so it's really important that when we provide this palliative care, we're working within these humanitarian hubs that are developed, and that we don't try going off and doing our own thing, because we know that we cannot do it alone. Then, of course, all of the UN agencies, of course, you know, the Food Agency, as well as the UN High Commissioner for Refugees, very importantly. Then the humanitarian health response organizations, such as Médecins Sans Frontières and the Syrian American Medical Society, the International Rescue Committee, all of these, Save the Children, Oxfam, you name it, they get involved within here. And then on the ground, the response may include hospices. It may include faith-based organizations such as World Vision, the Jesuit refugee community. It is a very important group, and it could involve palliative care organizations. And we saw, especially with Ebola, that the Good Shepherd Hospice was involved in Sierra Leone and did wonderful work. And as a global palliative care community, we couldn't go in and help them, but we could raise resources. So at least they had the resources to provide the palliative care. So we need to see humanitarian palliative care response within the greater palliative care community, because we are one body. And while we might feel we have few resources, if we look at what we all are together, we actually are a wonderful resource. And of course, we think that healthcare is the priority, but it's not. You've got to do a needs assessment. There's got to be water, sanitation, hygiene, food and nutrition, shelter and site planning. And then within the healthcare, where do we bring in palliative care? Because saving lives is always going to be the priority. And if we were involved, that's exactly what we would want for ourselves and for our families and our loved ones. There is, of course, the danger when your water and sanitation gets disrupted. Communicable diseases run rife. And so public health is so important. So again, looking at how we fit in, and what are the human resources that we need, and who's prepared to do it? Because palliative care in these situations can be going into dangerous situations. Do we have the training? And much as we say to the humanitarian groups, you need palliative care training, we need to look at ourselves as well and say that as palliative care practitioners, we need to learn about how to provide a humanitarian health response, because we never know when we might be caught up in floods like they were in South India a year or so ago, when the palliative care organizations were magnificent in their response. And so we have this coordination, and it really does help us to see palliative care as part of this big picture of health and of relieving suffering. And so if we look at some of the things that were happening, and I do advise you to really try and get a copy of Neglected Suffering, because it was a rapid assessment. It was an assessment that involved the community really well. It was led by Dr. Fazana Khan, and this was done in Cox's Bazar, and Dr. Megan Doherty, and they trained very quickly Rohingyan youth to participate. And Pal Chase was part of the support within that group as well. And what they found out was really what they expected, was that there was no known palliative care provision. So yes, WHO was there, MSF was there, all of the major humanitarian health groups were there, but there was no specific palliative care provision. There was intense emotional and spiritual suffering, as you can imagine. And we know body, mind, and spirit is interlinked. And so when you have this type of suffering, of your spirit and your mind, it's going to impact on your body. It's going to intensify symptoms. It's going to produce symptoms. And 75% of those that they assessed had pain without having access to basic palliative care medications, including opioids. And because they had to pay for it, 60%. So this impact of poverty, and you can imagine when you are leaving your country behind in a hurry, you're going to have very limited resources in general. And that 94% of families did not know how to provide care, and yet within this humanitarian refugee camp, it was mainly the families that had to provide the care. So nothing really greatly unexpected, except perhaps the extent of the pain and of the lack of affordability for pain medications. And so really to lift up, they identified all these different gaps. And from research that has been coming out of refugee camps in northern Uganda, where there are mainly refugees from South Sudan and from the Democratic Republic of Congo, they were finding things that were very similar. That was interesting. So we had this research coming out of Asia and research coming out of Africa as well. And really what they showed similar gaps. And they said what was needed was pain treatment, as we saw out of the rapid assessment. But pain treatment sounds great. So what do we have to do it? Even if you have the medicines, do you have the people trained, the people who know how to prescribe? Do you have enough prescribers? What can we learn from the palliative care field? Can we look at what is happening, first of all in Uganda and then in other countries with nurse prescribers? But then do you have enough nurses? And the answer always to all of this is no. They needed essential medicines and equipment. And one of the great challenges that we are seeing with the resources that come from WHO, they have these amazing packs that are all there ready, waiting to go. And they have packs that contain opioids and packs that don't contain opioids. And what they were finding is in that nearly every country, because of regulation within the country, they were saying, we want the provision, but we don't want the opioids because we don't have the systems in place to manage the opioids. So a lot to be done around advocacy, about in-country development. They needed training. So an admission, we need help. We need help coping us with all that is happening to our body, mind, and spirit, and these people that we are seeing suffering, but we don't really know how to do it. And then, of course, within these situations, you're never going to have enough formal health services. And so home-based care, and in this situation, there was so much to learn from the HIV/AIDS epidemic in Africa, because certainly for us in Africa, that led to this huge expansion of community care workers, community health workers, whatever you choose to call them, who have ASHA workers in India who have a basic training but are expected to do so many things. So we need to look at how do we rapidly train people to provide home-based care services. We want to empower the communities. And so a lot of palliative care work is about empowering communities. And then, of course, as we've spoken about, this intense, immense suffering that we're seeing, both spiritual and psychosocial, with people who are no longer linked to all of those structures that we take for granted. I take for granted that I'm linked to my church, that I can go to church on a Sunday or during the week, that I can call my priest if I have some kind of religious or spiritual question. And those people might have had it as well, but they're totally cut off. They might be cut off from all that is familiar. They're in strange surroundings. And so the pain is intense. How do we deal with that? This intense suffering as palliative care practitioners within this area that requires so much from us. So we know where the humanitarian crises are. That's quite easy. We have an idea of the palliative care needs from research that is coming out from Greece, from Ukraine, from Africa, and from Asia. We don't know the numbers. So even though we've had this wonderful World Atlas, Global Atlas of Palliative Care, in the second edition, which came out last month on World Hospice and Palliative Care Day, these people are crossing borders so often. We actually don't know what the numbers are. And can you do an estimate of numbers in Cox's Bazar and take that same estimate number to Ukraine, to the borders of Ukraine and Russia? Probably not, because you're dealing with different populations. So the need there is for palliative care. I've said that there is within humanitarian situations, very sadly, increased morbidity and mortality. We know that there are those with pre-existing conditions, of course, but they're often cut off from the resources that they need for their condition. Have they access to insulin? Do they have access to antiretrovirals? For those with renal failure who are on dialysis, we know that they're going to die because they're not going to have access to that as well. And what about the babies? A lot of babies are born prematurely simply because of the external conditions. Do we have within these situations the resources to deal with an increased number of premature babies, of birth trauma, because the mothers can't reach any kind of health service? And of course, all the other conditions that come along with babies, congenital, genetic conditions. And then, of course, we're talking about not just individuals, we're talking about families and whole families that are so seriously affected, and the bereaved. So our social workers, our chaplains, our counselors, how do we use the limited resources to the best that we can? And then even within this highly vulnerable group, there are groups that are even more vulnerable. We've spoken about the children, the pregnant and nursing women, the older persons. How do we care for them? And all of those affected by any type of progressive life-limiting illness. So some of the things that we have learned is that you must involve the local community from the beginning. If you can start training them, if you can identify through a needs assessment what resources there are. There may not be palliative care, but there might be counselors, there might be psychologists, there might be faith leaders who can be brought in and involved. It's really important that we don't allow a dependency, that we don't come in and do everything, because what happens when we leave, and I always like the MSF plan, is that when they go in, they have an exit strategy as well. Because our job is not to just provide palliative care, it's to build the local capacity and to develop their leadership. We can be there, we're the mentors, we're a resource, we're a Zoom away, or an SMS away, or a Skype away, whatever type of communication that we can use, we are there, we're available. That's what makes life so much better now. And then the other thing is, we don't go in with our ideas and our culture. We have got to be extremely culturally sensitive so that what we do is culturally acceptable. And even here within South Africa, I have to recognize that for many of the people that I work with and the patients I care for, the role of their traditional healers, of their sangomas, and their rituals around dying and death and funerals are really important. And I have to be extremely culturally respectful. And that's in a normal situation. That's not within a humanitarian situation. And as I've said again and again, we are not strong enough. We cannot do it ourselves. And palliative care is about teamwork. And we have to learn to work with different partners. Might not be those we usually work with, but isn't that exciting to meet new people and to learn new skills? Then we've talked a bit about the people we meet. I've spoken to you about all ages, from that baby or that baby before birth until someone of great age, and all the ages in between. We've spoken about the loss and the grief, but what about the very real fear? Going from one area to another, and often not accepted by the local community. Feelings of guilt maybe at who they've left behind. They couldn't take their elderly parents with them. What is happening to them? What's happening to my brother who's in another part of the country? All of these, and fear for their own lives. What are they going into? Are they going to be able to survive? What is the future? The hopelessness. Because they could have been people well in control of their own lives, and suddenly all that control is taken away, and there aren't any known plans for what's going to happen in the future. And of course, leading to serious depression. And if we're dealing with depression, can we train counselors, but do we have the medications as well that may be needed? And humanitarian situations push people into poverty. And so if you're already living in poverty, it makes your poverty even more extreme. And then, of course, that extra that we don't want to think about, but the anger that we see that arises, the angry, not just the youth, older people, that leads to aggression, that leads to assault, that leads to sexual abuse. All of these are things that we see within the humanitarian context. And complicated grief, which is on a huge scale and across all ages. And those of us who've dealt and for years with grieving babies know that they may be the easiest if you can give them love and comfort. But as their children get older, as they become adult, it's harder to deal with. And that grief is compounded by their poor living conditions. They're living in tents, they're living on top of each other, they're dealing with the floods that come and destroy their tents and what they have. And with all of this, they have very limited support and spiritual, psychosocial and spiritual support structures. How do we as a palliative care community, and these are a lot of questions that we haven't got the answers to. You know, we're very good at doing it on a one-to-one basis, on a family basis, maybe in a small group. But when we're faced with these millions, 443 million people who are all experiencing a degree of loss and grief, and then when we grieve, when we feel at a loss, we would like to go and have a private place. There aren't any private spaces, unless you go out and maybe onto the fields and can walk. And the impact on children, of course. We see it in their drawings, we see it in their behavior, we see it in their regression. Some children are seeing things that no child should ever see. And play is so important. So when we go into these situations, we need to make sure that in amongst all the tablets, all the medications, the opioids, and all the other tools of the trade that we take, that amongst those tools of the trade, there are things that we can use for play. Because even ordinary play has an impact. And I'm not just talking about children here. It's good for us to play as well. How do we get adults to laugh? Do something fun with them. Do something that pushes their boundaries. Do something that brings them together. And it grows the children. It grows their imagination. It helps them to think stronger. It builds their brain function. And it leads them to relax, to feel part of groups again, and to distract them, even for a short time, from other issues. So group therapy is the way we are finding we have to go. The numbers are large and the resources are few, so how do we do the best that we can? And within group therapy, we can provide, if we are trained in this, we can provide a safe atmosphere for the child and the adult to work on their problems and also to feel again part of community, which is so important for them. They're broken away from their community and they have to build a new community. And so art, we can get them to draw. We need simple things, crayons, pencils, paper. Sounds simple, but not very easy to get in humanitarian places. So it might be helping them to draw on the ground, taking stones and expressing themselves with their artistic creations, taking leaves and sticks. And so I think that I love this quote. And this is one of my favorite chaplains who had an amazing ability to get children to express their fears about death and dying and illness to him simply by getting down to their level, because this is where children's minds and hearts and souls meet. And what we're trying to do with the children, and if we think about it with the adults as well, is to give them the simple miracle of an ordinary life, to make life as normal as we possibly can, which is what we try to do with palliative care, by addressing their physical, their spiritual, their psychosocial needs, and respecting their culture, including the culture of childhood. And to look outside of ourselves for the resources. The World Health Organization has an incredible number of resources for psychosocial support in humanitarian situations and in all the UN languages. So go to the WHO website, make use of that. Don't think that we don't have to reinvent wheels. We can take an existing wheel and use it on our palliative care vehicles. And we need to collaborate, to identify and to collaborate with our local mental health practitioners. And they may be traditional practitioners. They may not be the psychologists and the psychiatrists and the social workers, but we need to respect that these are the health practitioners that the local people know and feel safe with. And so we don't come in with our superior ideas of what should be done. We accept the wisdom that is there in local resources. And the spiritual distress. You know, I think all of us sitting here, we can, if I said to you, what is the meaning and the purpose of your life? If you thought about it for a moment, you could give me an answer. But if that is suddenly taken away from you, if you have all this emptiness where before you had it all mapped out, you had it all in control, that future is taken away and you feel that your life no longer has the meaning and the purpose. Perhaps you're a parent, you've lost your children. Perhaps you're a child who had to leave your elderly parents behind. This overwhelming feeling of hopelessness. What is there? What is there in the future? As one said to me, it's just this, he said, when I look at the future, all I see is black. I can't see even a speck of light. I can't see anything. I feel totally disconnected from life. And because we know that spirituality is about meaning and purpose, take that away and we've broken our spirituality, our spiritual strength. Take away our connectedness, that feeling of self-worth, our connectedness to ourself. Take away our connectedness to those that we love. It might be a break in our role. I might have been the person in charge of the family and suddenly I can't do it anymore. Our connectedness to the nature that we know. I'm sitting here and I look outside and I can see the trees and the bird bath and my dog and my cat. take that away from me, and you've actually not just taken away the context of where I am, you've taken away the things that give me meaning in my life. You've taken away my spiritual support. And on top of that, take away my connectedness to my faith groups, my faith strength. So we know that faith-based organizations and spirituality and faith, we know they're two separate things, that for many of us, they are very connected. And we see that they are very big role players in humanitarianism. How do we work with them? How do we take their knowledge and skills and wisdom and bring them so that the people that we're providing palliative care for have the benefit of that? And those global organizations often have links with local organizations. So we can help to link them, and we can help to strengthen connectedness and a search for meaning, even in small ways, helping them to see in a small way what they have achieved, even by leaving behind the dangers. They have achieved something. There's a purpose. What are they here for? Help them to find that connectedness with others in that community. It might be a new connectedness with a new nature around them, with a new connection to whoever they see as the sacred, and to share with them what Viktor Frankl said. And if you haven't read Man's Search for Meaning, I think it's a central reading. Who was in the concentration camps. He was a Jewish psychiatrist in a Nazi concentration camp during the Second World War. And he developed logotherapy. He said, when we are no longer able to change a situation, we are challenged to change ourselves. So helping them to develop inner strength. So we see in the current settings the limitations that I've already explained to you. We see that palliative care services have not been made essential components to pandemic response planning, to any humanitarian situation. And we know that there are no quick fixes, that everything that we do takes time. We will never have enough resources, so we are challenged. But there are key areas where we can intervene in communication and goals of care. Where are our specialities? Symptom control, psychosocial and spiritual care, end-of-life care, and staff support. Never forget that. Because we're also helping people around death and dying and in funeral services and traditions. We've looked at the triage categories in humanitarianism, those that need immediate care, so that's saving lives. We can integrate perhaps with symptom control, symptom management, and psychosocial support. In delayed care, we can provide palliative care and symptom relief. Where people need minimal care, we know they're going to be the last ones to get attention, but we may be able to help with symptom relief and psychosocial and spiritual care. But what about the group they call the expectant group, where survival is not possible given the resources available? And that we feel is absolutely where we have a wonderful role to play. How do we care for the dying? How do we support their families? And the World Health Assembly, COVID has brought to their attention that palliative care must be part of the humanitarian response. We have numerous publications and a growing number of publications. The field manual for palliative care and humanitarian crisis is freely available online through Oxford University Press. I've spoken about the Sphere Standard, which you can just go online and read. We had a series of webinars and developed briefing notes that you can find on globalpalliativecare.org. And we did one webinar and a briefing note on palliative care in refugee camps and humanitarian crises. Resources are there, you can use them. And we see that wonderful, wonderful development in Pallium India and the Palli COVID Kerala was online resource. and the many, many countries and individuals who have been trained. So make use of these fantastic resources. There have been other situational analyses done. One is amongst the South Sudanese living in North Uganda, very similar responses and results to Cox's Bazar. But throughout, wherever it's been done, we see the crucial role of community health workers from the community who speak the language, who know the culture, and who can help and interact, and you can bring back to us the wisdom of that community, the wisdom that we need to learn from to provide effective care. And this is Fazana with her group. Very interesting. In most parts of the world, it's mainly women who are the community health responders and the community health assistants and palliative care assistants. But we find often in humanitarianism, it is men who come forward. Simply because maybe for the fear of going into the different areas. And they can not only provide the work, but they can improve the understanding of good health as well and help the patients that they care for. So our community health workers are a crucial, essential, wonderful part of our healthcare teams. And certainly here, wherever I work, the majority of the people I work with are community health workers. And then, of course, not to forget to look after ourselves. And this is Vicky. Vicky is an amazing nurse who just set up and runs a wonderful program with the South Sudanese refugees in northern Uganda. Very spiritual person, but recognize that every morning there needs to be a degree of psychosocial and spiritual care, because how can we care for others if we don't care for ourselves? And we know that, but we're often not very good at it. And I think for her, the meaning and purpose that she is called to do God's work, so that the spiritual strength that she gets from that, and Vicky has really done wonderful work. So we need to move forward. We need to move forward with the values that we have as palliative care practitioners, because there can be very difficult ethical decisions that need to be made. When I was in Turkey and working with the Syrian American Medical Society, a heartbreaking story came from the last gynecologist and obstetrician in a particular area of Syria, in an underground hospital with the bombs going off above her. She had to make a decision about which mother to perform a cesarean section on, knowing that the other mother and baby would die. And this quiet spoken, tiny lady, when she spoke about it, she had us all in tears, because isn't that awful? And so many times an ethical decision has to be made about who to save and who to leave in humanitarianism. And we can help with that. We can help by using our ethical principles rapidly in those situations. We've talked about the importance of healthcare workers. And we need to remember that we are this global group. We're not a little group who's just going into one place. We have this incredible palliative care resource to take into these really vulnerable situations. And here, the UN Secretary, previous one, Antonio Guterres said, it is the most vulnerable, women and children, people with disabilities, the marginalized, the displaced, and refugees who pay the highest price and who are most at risk of devastating losses from the disease. And so as palliative care practitioners, all of the things that we take when we go to our patients, whether in India or here in Africa, the compassion, the recognition of our combined humanity, the common suffering and illness and dying, it doesn't change whether you're in a humanitarian situation or in a very fancy hospital in New York. It's our shared humanity, and we need to be there to respect and uphold everyone's dignity. And so our recommendations, Palliative care needs to be integrated into the humanitarian health response so that every humanitarian health responder has a degree of palliative care training. We need even more guidelines. We have basics, but we need more, but especially for the more vulnerable groups. We need essential palliative care packages that can become part of the WHO packages. And yes, we do need to have those brave enough to be part of rapid response teams who have training. And for the palliative care team, we need to recognize in humility that we need training and competencies from the humanitarian health field. And the others we have spoken about is the psychosocial support. And this is something that Moira Ling, who many of you in India know, was told by one of her medical students that she was teaching in Gaza. They talked about humanity until infinity. So that means humanity always. And this health worker who said, and I am human, by the way. So it's our humanity with their humanity tied up there. So we need a global strategy. We need to accept that palliative care needs to be in humanitarian places. We need this inclusion into all health systems because we believe in universal health coverage. And we need education of everyone. So that we can say with Dr. Fazana Khan, nobody seems to care for these human beings, but we do, and their unfortunate families. Whatever we do needs money, but we do have resources. Can we build a strong palliative care force who will be a light for these absolutely disadvantaged people? So thank you, Fazana, and thank you to all of you for listening to me. And I'm very happy to answer any questions if I can.
Thank you so much, Joan. Your characteristic of your presentations delivered with so much grace. You really opened our eyes to this whole world of suffering where we as palliative care providers do have a place. May I just, yeah, we'll just stop sharing the screen and then I'll invite comments from our, yeah. So while we do that, I think one of the, for me, a reflection from me is how often do we think about chronic poverty as a humanitarian crisis, especially in a country like India, where it is so rampant that it becomes par for the course, and it's it's something that we've learned to live with, which is it's terrible. I think it was Arundhati Roy who said, never forget, never not see the vulgar disparity, and to see chronic poverty as humanitarian, an ongoing humanitarian crisis, I think is something that really struck me very sharply when you mentioned it. And I think in palliative care, since we're already seeing the most vulnerable cohort of, the ailing, the alone, the infirm, the impoverished, and the elderly. I wonder, Joan, if you could comment a little bit on, where these people fall when triaging happens. Because very often triage is such an ethically, it's such a convoluted space. And my understanding of triage has been you offer the resources to people with best chance of survival. So where does that leave our palliative care beneficiaries in that case?
And this, thank you so much, Smriti. And this is really a great challenge to us as advocates for palliative care, because many of that group you were talking about will actually be last on the list, because first on the list are those whose lives they can save. And that's what most of people who go into humanitarian health and response are after. They want to save lives. And so if there is somebody that if they had to choose between a young, healthy person and somebody who's nearing the end of life, they would choose a young, healthy person. And at present, there is very little being done for that person who is nearing the end of life, or who may have a disability, or who may be, like me, an older person as well. And that was the choice that I spoke about as well, even from the beginning of life, to choose which mother do I save, which mother has the best chance of living, knowing that that other person is going to die. So within triage, they're very hard decisions to be made. And this is why we as a palliative care community, I think, have not only got to be integrating into them, but we've also got to have people who are in response teams who are there to look after this category, who will come last. And it's a very sad thing to say, but they will come last. And the other thing is that we need to be doing even more to train and build capacity in a community. So as if there is an earthquake or a flood, that within that country, there are adequate palliative care resources. Because often with palliative care, we get caught up in the beauty of what we do. And is it beautiful? I don't think there's a more beautiful part of healthcare than what we're doing. But sometimes our vision goes from being big to small, because that's what we deal with. But when we're dealing in humanitarian, we've got to take that vision and make it big. But we can only do that if we are prepared to actually take the steps to advocate, to educate, and perhaps for those who are brave enough to become part of response teams as well, to be trained in humanitarianism. So there's no easy answer to that. It's saying that, our patients were probably going to come pretty low down on the priority list within the present health response.
Absolutely. And I think there's several people here who have attended some of the Palli-COVID sessions. And in that, Moira, who is who you were talking about in Gaza, she's also addressed the triage, the ethical goal setting bit quite beautifully. It's part of the ebook, the resource toolkit, where we've talked about it. But I think for us, it's also important to remember that what this pandemic has brought is it has given palliative care an opportunity to make its worth felt. I mean, in COVID specifically, the constellation of symptoms of COVID have mapped so closely to things that palliative care providers have been familiar with, you know, the breathlessness, the distress, the agitation and stuff. And I think one of the most valuable pieces that we brought to the table was communication, like you mentioned, Joan, because people are trained in emergency medicine, they're trained in critical care, they're not trained really to talk to families about impending death, about, you know, bereavement, and especially at a time like this when we can't even be with them when they're dying. So can you just tell us a little bit about, you know, your experience? I know in South Africa has been as painful, I suppose, and where you see communication fitting in to, you know, something that palliative care has really pushed. You know, that communication is as good as any medical skill. You need to constantly upgrade it. So, what are your thoughts about that?
Yeah, absolutely. I totally agree, Smriti. And I think that we've got to get more training into undergraduate training, so that whether you're a social worker, a chaplain, a nurse, a doctor, that you do have not just basic skills, but you actually have the skills to deal with these difficult conversations. What I also did when COVID started here, and people said to me, help, the nurses don't know what to do, and yet they can't come for this training, is I did a letter giving them tips about how to communicate. And many of them contacted me and I said, I'll be a resource person. So you can be a resource person, finding different ways. So we talk about Zoom, but what I found was the nurses, when they came off duty, they didn't want to go into a Zoom call. They were too tired. You know, they wanted to pick up a phone and call me when they needed something then, or they wanted to send me a WhatsApp. But they didn't have time for an hour's Zoom training. So I think we need to look at different ways that we can use the skills that we have to build capacity, because it's not just about what we can do, it's about how we build that capacity in people, and how we model it as well. Because if we model it well, they will want to do that as well. So it's such an essential skill, isn't it? That we we know that, you know, even chaplains don't always have really great communication skills and dealing with end of life issues. We hope the social workers and psychologists and counselors do, but nurses and doctors, and especially nurses and doctors who like working in crisis situations, who like intensive care, who like humanitarianism, who like surgery and trauma surgery, communication comes pretty low down on the skills that they want to develop. So how do we, and I go back to us, that we haven't done enough. I honestly don't think we are doing enough. We're doing a lot, but are we raising the profile of the need for palliative care communication skills? Are we raising it high enough that people want to say, oh, I want that, I want to do that? And how do we do it? Do we have a strategy for that? And also not being too, shall I say, too high and mighty and saying, my palliative, most of the palliative care in Africa gets done by community health workers, working with professional nurses, with doctors if you're lucky, but we don't have many doctors in Africa. We have a huge shortage. So the nurses are actually most of the team leaders. So how do we train people on the ground to have these communication skills and to know when to refer up as well? So it's quite a complex thing, but we need it. And don't forget, communicating with children is every bit as important if you're going to work in this field. And people sometimes are hilarious in their communication with children. Other people, we should be natural. We were all children once. Can we not go back in our heads as to what it was that we liked at communication with children? And remembering that often in humanitarianism, we're communicating across languages with a huge language barrier. So I think a skill in learning to work with translators, and there is a skill to it as well, from the translator side, but also from your side, how to make that conversation flow, even though there's a third party who's who is helping you.
Absolutely. I mean, yeah, you've when you talk about, you know, children, at the best of times, we make a mess of things. So when there's a crisis on, it gets even more. I guess that gap becomes wider. We've spent decades unlearning how to be children, so it's very difficult for us to go back to that space. But and so we are actually going to be doing sessions about children, and we're going to have you on it. So,
my favorite subject.
No better person in the world. No better person in the world to teach us about that. We've had. So I think there have been lots of comments in the chat box, Joan, primarily of just affirmation of what is being shared and what you've talked about. Just to let everybody know that I have shared the link for the Oxford, the free, where you can download the field guide for palliative care and humanitarian crisis, which is edited by our friend Marsha Glass and Alicia Waldman. And chapter 3, I've made a special mention. That's the one that Joan co-authored. That's also available for download. In addition to which, there is the Sphere handbook that you'll find in the chat box. So these are, I think, really starting points for all of us, Joan, because like you said, palliative care in humanitarian settings is such a new field, and we're really sort of finding our feet. But I think what's nice about having these kind of conversations with, there's 58 people present in this room today, is that that's 57 more people who you've reached out to, and I'm sure sparked something in. And it's all really up to us, like you said, to really educate ourselves, because we don't have to wait for a massive disaster to take place. There are smaller crises happening all the time, and we do have a role in it. I think I keep saying this, I think palliative care people need to step out of the echo chamber a bit. And,
yes.
and we really need to connect.
We tend to think of ourselves David Clark wrote a wonderful book, A Little Bit of Heaven for the Few, talking about the hospice movement.
Yeah.
And even though programs like Pallium India reach so many people and impact on so many more, if we look at it in the whole context of the need, it remains a little bit of heaven for the few. And it's our fault. We just need to keep on being advocates. We have to be advocates all the time for palliative care, for the importance, because when COVID happened, we weren't prepared. You know, they were saying we need palliative care, but we as palliative care practitioners, we hadn't recognized that we needed those humanitarian response skills. We needed to know how to work quickly because we're so used to in palliative care having time. It's you know, we have time to talk to our patients. We have time to talk to the families, to have family conversations. But suddenly we were, and this has been good for us as a palliative care community. And what we do need to do now is to lay down all the learning that we need for the next, because there is going to be another one.
Yes, and I think what this pandemic has thrown up in our faces is a new group of vulnerable people, and that's the healthcare providers, who are really stretched to the limit. And are going through such massive mental trauma, emotional trauma. And we heard from people in Italy and stuff that a lot of the trauma came from not knowing how to talk to the patients, not knowing how to talk to the families, and that compounded trauma of the volumes of deaths taking place. So let's not forget that, in all of this, our healthcare providers are also right now in need of some sort of compassion and probably a palliative care approach. And that's where we show up for them as well. So I know that you do that very beautifully, Joan. And, there is a group of us who meet and we share that space. But really, that's something that all of us could do on our day-to-day lives. Thank you. I'm just going to, we have 10 minutes. So would anyone like to unmute themselves? There's a beautiful comment in there saying that the session has made people feel more human, Joan. Thank you.
That's lovely. Thank you. Thank you.
And we have 10 minutes. So I'm going to just invite people to switch on your videos, unmute yourselves.
What's happened there?
No.
They're shy.
Well, that's very unusual for this group, I'll tell you. I think they've never been shy to share before. I think it's just been a high impact session, I suppose. Yeah, someone has said never shy.
Thank you, Joan, for a very, very informative session. This actually expands our horizon, and to think beyond, at least for me, think beyond what I'm doing. I'm handling cancer patients, so I deal with the palliative cancer patients, and I had actually not thought of palliative care in humanitarian crisis. So you've opened up an absolutely new outlook for me, and thank you for this. And yes, it's been extremely informative. Thanks a lot, Joan.
Thank you so much. Thank you. And just remember, each one of you is an advocate. We have these super advocates like Dr. Raj Gopal and Catherine Pettis, and people like that. But actually, they're taking our voices. So we need to make our voices stronger to support them, but also feed into them. But each one of us has got to be an advocate. If we really believe in palliative care, we've got to be promoting it all the time, not just in our words, but in modeling it as well, in the way that we approach people, the way we talk to them. and with ongoing learning. And as Smriti said, how do we look after each other? We're really quite good at looking after other people, but how do we look after ourselves and each other, the people that we work with? It's so easy to look past them, but be aware that when you're working in this field, whether it's in this big humanitarian crisis or another type of humanitarian crisis, or just the day-to-day trauma of working in palliative care, and it affects us all emotionally, is that we have to have a sensitivity to others.
In the next couple of weeks, we're going to have Dr. Atul talk to us about what the response in Kerala was to the floods, and also to the COVID situation. He was in the control room. He still spends a lot of, there was a time he didn't go home for months on end because he was just managing all the contact tracing and making sure that the palliative care patients were not being left behind. And he did that for COVID. He's done that for the flooding. I think we'll really see another sort of ground up side from his presentation. And in the week following that, we'll be doing a session on trauma-informed response to palliative care, where we will talk specifically about how we look after ourselves and one another while providing care for those that we serve. So that's what the next 2 weeks look like. And I will urge all of you to please go through the palliative care and humanitarian aids in humanitarian crisis book. It's not a very big book. The chapters are designed to be easily read. There's lots of wonderful bits of information in there, and we can have a more interactive session if you can pick and choose the chapters. It's all very well laid out. So thank you again, Joan.
Thank you.
I'm sure there will be questions trickling in once people have absorbed everything that they've learned today. The slides will be shared with everybody, and also the recording of the session. And as and when we get questions, we will certainly forward them to you, Joan. Thank you for being in this world. Thank you for everything that you do. And thank you for
inviting me. And enjoy the rest of the course. And just go on to be great palliative care practitioners and advocates. Thank you.
Thank you so much.